Dr. Belyansky, it's an absolute pleasure to speak with you today. And my first question is you obviously started in a fellowship that was pretty heavy in open ab wall. What made you transition to a robotic practice, and how did you even kind of get interested in that?
Yeah, sure. Great. Hi, Charlotte. Very nice to be here. Um, as you mentioned, my fellowship was laparoscopic, and as well as when it came abdominal reconstruction, was all open. So we had a combination of kind of plastic surgery, as well as we're doing external oblique releases. And I guess it was a journey which I slowly transitioned into in the first 4 to 5 years of my practice. And it wasn't spontaneous at all, but when I was in fellowship, my first year out of fellowship, I heard of Alfredo Carbonell back then doing robotic abdominal reconstructions or robotic transverse abdominis muscle releases. This was 2013-14 year. I haven't met Conrad Balliser yet, and so Conrad, as you know, was the first fellow of Alfred Carbonell, and actually, now that I know the story behind the scenes, I think Conrad was the first one to do the actual robotic posterior component separation, and then working together with Alfie. And Alfie was Alfredo Carbonell at that point was kind of very well recognized authority in hernia world, and he was kind of was the first one that I know kind of was fairly vocal initially in the early 2013-14, talking about robotic abdominal reconstruction. So I personally did not do my first robotic case until 2016. And so, but my personal journey was kind of really nothing really to do specifically with a robot, but kind of being passionate about minimally invasive surgery. And then slowly, on the one side, I was trained to do laparoscopic eye pump repairs. On the other side, I was trained to do kind of like you. I was trained by a master surgeon to do a beautiful open component separation, which was mesh outside the abdominal cavity. So we were doing this beautiful extraperitoneal repairs. Todd Henneford taught us how to do pre-peritoneal dissection. So we weren't doing TARS yet in his fellowship, but just peeling peritoneum, which is actually much more difficult technically procedure to reproduce. And I think that's why it really never took off, except Carolina's guys still do it, I think.
Yeah, totally.
And so kind of as a young surgeon, you start seeing patients back, and again, this is just kind of personal experience, sometimes going back after my cases, like after an eye pump repair, and not always, but a lot of times seeing adhesions, dealing with other complications. And sometimes complications would be related to the mesh, a type of mesh that was used. Sometimes they're related to technical procedures. Sometimes it's just bad luck, but having mesh inside the abdominal cavity, I see a lot of issues related to that. Again, the case practices like mine now, it's hard to say what is the actual denominator, right, of those problems. So you see it. So that's why it's hard for me to still say eye pumps should not be done. I think it's still a rare occurrence. But when you see it, you start asking yourself, why are we doing it this way through small incisions and the other way through open incisions? And then watching the work of guys like Conrad Balliser, which I personally met Conrad in 2015 in Milan when there was a World Hernia Society. That was 2015, and I remember there was one night. It was a kind of glorious night. So all of us were there. There was Conrad. I met him for the first time. Yuri Nowitzki, Alfie Carbonell, Todd Henneford was there. Vedra Augustine was there. So there were a bunch of us that were there hanging out, just in a small mamas and papas shop, drinking some wine. And we closed out the place. But I remember that night, I really talked to Alfie Carbonell about his robotic experience. Mm-hmm. And I did not have, and this is 2015, I did not have, this is May or something, 2015. I didn't have access to robotic platform at the time. But I was really curious with what Conrad was doing. It was what Alfie was doing. I just really wanted to kind of gain that experience. I was trying to still understand, is it a gimmick? Is it a real thing? Mm-hmm. Or is this, or is this just something that is going to be fad and we're never going to take off? So I had no clue. And of course, back then, a lot of us who were laparoscopically trained, we used to say very commonly, robotics is for people who don't know how to suture, right? That was a very common phrase thrown around, right? And so, I actually asked Alfie if he thought I can do this laparoscopically. And I don't know if Alfie meant it or not, but he was very encouraging. He's like, you should try to do it laparoscopically. If you don't have access, I think you can do it.
Mhm.
And so it's just transitioned personally. Kind of, I initially started doing the transverse abdominis releases laparoscopically. Then, kind of picking up some of the techniques from Jorge Diaz, who was doing laparoscopic ETAP access surgery. We combined that later on. That same year, 2015 was the first time actually August 2015 was the first time we did ETAP, and then a couple of more in September we did more, and then kind of it took off. But the ETAP access surgery was designed for laparoscopy, and then as I started doing harder cases, I was kind of taken back because I actually, tell you the truth, I did not expect to see a huge difference in outcomes when doing this through small incisions as compared to when we're doing this open. And, it's kind of one of those things, as you see this happening, you're like, oh my God, you're kind of blown away a little bit by the fact that you can, initially I was very slow, not aggressive sending them home. I would send them home post-op day 2. And to me, that was like groundbreaking, really, because a lot of TARs that we used to do, or day 4 would be early when they would go home. Of course, nowadays with some of the ARIS protocols, we can get aggressive with open cases too. But still, that was 6-7 years ago, and anyways, it was a fairly fairly kind of a practice changing experience. And so, but what I noticed is the higher BMI patients were more difficult to do. And I actually had a number of conversions of BMI greater than 35, which, as we see 35 to 40 BMIs quite frequently. And still, for me, for open cases, 40 and higher would be kind of contraindication to open surgery. But laparoscopy or robotics, you can do it because the wound comfort. But the question is, can you deliver the surgery? Can you reproduce the surgery laparoscopically? And I think I learned, kind of based on my experience, at 35 BMI higher, becomes quite difficult and the difficult part was not the suturing part. It's the dissection itself. It's the fact that you have to have this thick abdominal wall and you have to dissect laparoscopically. And typically it would take 40 minutes to do a side laparoscopically. And it's not an easy dissection, but the fine point of dissecting was a hook and dividing the posterior rectus sheath. And as the BMI got higher, that was a very physically tasking procedure. Forget about the closure. Sometimes the instruments, when you try to close, are starting to bend a little bit. And so, that's kind of like, so the people who truly benefit from, minimally invasive surgery were not really getting addressed in my practice laparoscopically, really. Like I had a cutoff. And then, so I decided, well, let me try this robotics business. And again, I've been working with Conrad at the time, and with just 2016, I did my first robotic TAR. So that's kind of like a long story how I got into robotics.
No, it's awesome.
Yeah.
I love how you mentioned when I was there, you mentioned that the learning curve, I think a lot of people think, oh, I can do laparoscopy. I know the anatomy of complex ab wall, but you mentioned that the learning curve for yourself with the robot is around 200 to 300 cases. Talk to me more about that. Explain to me why you think it's so many, and what are the things that are unique to the robot that really, need to be mastered in order to be as efficient as you are, because, your robotars are pretty dang quick.
Thank you. Thank you, Charlotte. So if you ask me after 25 cases if I was past the learning curve, I would probably ignorantly tell you, yeah, I'm past the learning curve. So I think you don't realize how much better you can get by 300, 400, 500 cases. And what I'm talking about is actually, there's a phases of learning how you use a tool. Initially, kind of like you have to look, kind of interpret, kind of think about what you're gonna do, kind of what you need to do with your hands. So kind of your brain gives you, but then at some point, as you transition, you become quite an expert in using something, whether it's a laparoscopic stick or open instruments for open surgery or robotics. It's just become, instruments become almost an extension of your hands without you even thinking twice which pedal to push, which gadget on the latch to pull on your hand controls. It's just becomes a physical memory. Same way as I think you and I talked about analogy of the stick shift car. When you first start learning how to drive a stick, it's not a smooth ride at all. And of course, you get better within a year, but if you compare yourself to like a year, then like a 5-6 years later, you become a much better user of this interface, whatever it is. And that's why I think really to become efficient, where you truly harness the ergonomics of robotics. I think it took me a while also. I got through it, I was started being quicker initially, but then a few months later, I worked in a lab with Eddie Parra. He is a surgeon colorectal surgeon from Florida, who has been doing robotics for, I think before I got in there, I think since mid 2000s, he got in the robot. And Eddie is a master user. He has thousands of cases right now. And I remember him coming down and kind of teaching me kind of how to reset myself. And he's like, Igor, because nobody really was teaching me initially. I was more concentrating about doing the procedure and forget about the ergonomics. So what happens, sometimes your hands are like this, you love it. Sometimes like this, your elbows are like this, kind of turned offside. It happens with people who are learning. And then the key is, imagine that it's just a small box and your hands stay with it, and you always kind of reclutch yourself back to its neutral position. And that just comes, I think, in my opinion, with being trained well, and as well as kind of like number of cases. So that's what I mean, like you become a super user. Mm-hmm. So the worst thing somebody can do is, of course, try to get you start using a new tool. So robot is a tool, right? Mm-hmm. A new tool. And then at the same time, trying to learn a new procedure. That's probably the worst of two worlds coming together right there.
Do you like worry at all that that's sort of happening with the robot? As we have a lot of ability to share our techniques, virtually now, that things just seem so much easier. That I think there's some people that really understand the anatomy, and so the application of the robot is just that it's a tool. But as you just mentioned, like if you don't know the anatomy and you have a new tool, like how do you feel about that in terms of really kind of disseminating the technology that the robot can provide to people that are doing complex hernias?
Yeah. So if I really come to think of it, is I'm a believer that information should always be shared. So I think, so there's two answers to this question. The first part is about, I think your question is about information being out there. So we're living at a time that's very different, nothing to do with a robot, but we're living in an age of social media when we are all attached to our devices, constant information coming in front of our eyes. And some of it is very useful, some of it is, and so it's up to the users to figure out what's useful, what's not. That's the hard part, perhaps. But I think it's great that there's, I think, a lot of educational videos or lectures, how to do it out there, which is free of charge. And actually it's the content can be very rich, where before it used to cost a lot of money. And now perhaps, money does not necessarily mean quality anymore when it comes to education. So the danger is trying to filter out what's useful, what's not. That's a whole different story. So, and that's perhaps that's the tricky part for people who are trying to learn new things. The other things, I guess, is new procedures that we're putting out there. Like if we talk about ETAP access surgery, kind of, it was very adapted much quicker than I thought it would be. And was this a good thing or bad thing? So I personally worry about it because I feel like it's a very complex procedure with a lot of places where things can go wrong. And yes, I worry about potentially inexperienced surgeons jumping into a very complex cases right away. And sometimes we say ignorance is bliss, until you get hit by a train, coming from the side. And people unfortunately will learn the hard way. That being said, I hope adult surgeons, or mature people who you would hope recognize where the shortcomings are, and they can be mature learners and have a good emotional intelligence to know when it's to say, this is above my kind of what I can handle right now, and let me seek help. And so the help is here. That's why I'm thinking. And I think it is much easier, I think, to learn a new procedure now as compared to several decades ago. I can argue that. The scary thing is it's happening very rapidly sometimes. And I guess what you're asking is, how do you know that we can control quality? And that's a good question. I don't have all the answers for that. But I think some of this, again, goes back to us educating, and those of us who teach this. I think besides teaching how to do it, it's very important at the same time to talk about the teaching about complications, and that's part of the sharing of the process. Teaching complications, what can go wrong, and really not encouraging people to just get at it, but really just consider whether it's for their practice or not, and then make the right choice for them, whether they should proceed with more complex repairs or not. I think like with anything else, okay, the final thing I'll say, there's a kind of a fat phase where it really shoots up, and then it's going to come down, and then it's going to level out at some point, and then we'll see over the next decade where it goes, where it ends up, whether it's something that's going to stay in the practice or not. We'll see. I know in my practice, I don't think it's going to change now, but we'll see what the rest of people do.
Why would you? I think that's like, to other people's points, like once you become an expert, whether it's like an open or robotic, like you obviously know there's, some people that do just straight up open ab wall, and they have phenomenal outcomes. You have the very old school HPB surgeons that are like, listen, this is the incision that I make. It's this big, and they have phenomenal outcomes. And so it comes to a point where like, if your outcomes are really good, like, right, is there any benefit to change? But there's also, I think, being one of the new people in hernia surgery, and especially as you start to see trainees, like the robot is here to stay. And we really have to teach people how to utilize it appropriately.
Absolutely.
Okay, so you have done, thousands of robotic cases now. What have you learned about the abdominal wall throughout your, practice?
Well, I think, what have I learned? I think my understanding of anatomy now is much better than a decade ago, even as of coming out of fellowship. That's kind of really comes with experience, but that has nothing to do with robotics. I think robotics just helps actually teach anatomy better, I think, because I think we've talked about it. So you can see things better. You can actually label the videos, make the videos nice for people to present. But I think in general, as a kind of a group collective, we understand a little bit more about some importance of neurovascular bundles, importance of structures. So I think we understand better the intimate relationship of the oblique muscles with linea simulnaris, with their contributions, distal contributions to anterior sheath and posterior sheath. I think those of us who do this procedures a lot, we're not just married to one space, but we're much more comfortable navigating between the spaces, whether it's a retrorectus space, preperitoneal space, subcutaneous space in the only position, intraperitoneal space. Sometimes it's still in my practice. I may use an IPOM repair, but very rarely than some other surgeons. But you just have to understand the risk benefits, and if you're going to do procedures, don't do it because it's a fad. Know why you're doing it, perhaps. So kind of that understanding, things that we need to understand better in the future. I guess that's another question. What do we need to work on? And I think as surgeons, abdominal reconstruction surgeons, we're not just hernia surgeons that, we fix hernias to prevent strangulation, incarceration, plug, take care of the hole however you can. We didn't used to close the hole, we just would patch it up. And so that would prevent strangulation, and we were happy with this. Now, then it moved to, like the pendulum moved to, most of us are saying that the defect should be closed, but we don't really have the true level 1 data to support this. And the reason for that is because I think we don't even have a good way to measure abdominal wall function. So when we communicate among each other, we're saying, okay, we're going to focus right now as American Hernia Society in core health. Okay, that's good. I think that's a great step, because that's kind of, and I think about core health, functionality of abdominal wall. And so, but the thing what we're missing among ourselves is, how do we communicate what is functional abdominal wall? How do we measure the functionality of abdominal wall? We need tools. So we can say, here is, kind of how we used to either Hercules scale about pain, or canalized comfort scale, we use for mesh comfort, whatever you choose. But it'd be great if we had something like that, an objective way to measure function. So we can say that we're actually be able to measure improvement of function. We can't even measure it because we don't have a way to do it right now. I guess like we talked, Dr. Rosen has published a paper with Biodex. I think we talked about that too. But it's a big machine, and I think we have to do something else besides that. Right? It is the only one that I know that can objectively give you a number measuring the function of like rectus abdominis muscle engagement. But what do you think about that, Charlotte? I think that's an important thing to think about in the future.
I think it totally is. And I think, as we start to fix these more complex hernias, people are getting pre-op pneumoperitoneum and Botox. The one thing that we do not understand at all is abdominal wall compliance, and we don't have a good measure for it. And certainly there are defects that are 10 centimeters that you can't close, and there's defects that are 20 centimeters that can close easily. And
Sure.
so there are certain things that we are missing. And I think, one of Dr. Rosen's new things is a lot of people say that when you do these transversus abdominis release, you do get a lot of advancement, but honestly, it's probably not as much as people actually realize. And part of just doing the TAR is to create enough space for a large piece of mesh. And then on top of that, now that you have these big defects and people are very, very concerned about the mesh, is how much mesh overlap do you need? Does the mesh need to be there forever? There are a whole bunch of questions that are just ripe for answering. And I think especially as you kind of become these a high volume hernia surgery, you start to really understand the nuances of the abdominal wall, and you realize how much data we are actually lacking when it comes to the right thing to do. And I think, in my practice, there is no great data to talk about what to do in a hernia that's between 2 and 8 centimeters. Certainly 8 or greater, you probably need a TAR. Under 2, you probably, can fix it with sutures, but there also is a whole realm of there's no standard, and you could do whatever you want. And there's probably decent evidence to support that you're doing the right thing. But I think, as we start to really understand it, and as you had stated, there's really not a good measure of, functional abdominal wall. And I think that sort of plays into some of the data that we're seeing that quotes high recurrence rates is we might have fixed things, but have we really established a functional abdominal wall for a patient? It's hard to say. And I'm sure it's different between people. And so it really, there's certainly an objective, the hole is fixed. I've covered it with mesh. There isn't, a recurrence, but there's this whole, subjective side of hernia repairs that now I can do what I want. And sometimes with these massive loss domain hernias, you really just have to kind of give them some, continuity of their abdominal wall. The fascia may or may not need to be closed because of the morbidity it would be to close that for them. And so,
sure.
I think there is just this next layer of understanding in terms of how do we actually as you mentioned, create a functional abdominal wall. What does that mean? And then how do we use individual abdominal wall data to determine how we're fixing these larger and larger hernias? And probably if you have a super compliant abdominal wall, you probably don't need as much mesh as someone that has a non-compliant abdominal wall. And so there are so many things that I think all of us kind of know about, but at the same time are very limited in terms of actually being able to study this stuff. So
absolutely agree.
That being said, you have been, pioneering and championing the robot. Where do you see robot hernia repairs going in the next, 5-10 years?
Well, I think, if it's hernia repairs, I wish I can kind of have a crystal ball predict, what's going to happen. I think we're going to spend time in the next decade probably catching up and making sure that really this last decade, there's a lot of new procedures. And I think in the following 10 years, I think we're probably going to be spending time studying certain things, kind of seeing how reproducible the techniques are. And I think our field is also going to start transitioning to more and more with over the next couple of decades, not over the next couple of years, couple of decades, more becoming a true subspecialty of kind of where people who are doing this are specializing in this and actually having a specialized year of training, like you've trained with Dr. Rosen specifically on abdominal wall reconstruction. So that's there's that in mind. I think robotics, at least look at my own practice, I just don't see this. The more I've been doing this, the longer I've been doing this, the more and more cases I'm doing robotically now. I would say probably 90% of my practice now is robotics, and the rest is open. Where before, the open cases used to take probably up to 40% of the practice at one point when I was and so that's really taken over. And I can really push the envelope with some of the comorbidities because of the robotic tool and the patients, where before repairing those patients were prohibitive because of open cases and wound complication. Surgical site occurrence obviously is higher and higher being my patients. So I think hopefully a lot of things can be standardized. I think the robot is going to stay as a tool in the hernia world. The robotic technology itself, I think, perhaps with time will become less of the physical footprint in operating room. Again, this is more of next couple of decades. More so for oncology field is going to become interesting. I think they're going to have more of kind of imaging overlaps with CT scans, and it's going to be very good, cool for oncological cases to really get a clean resections on some difficult to get to tumors. But perhaps in our field, we do a lot of kind of repetitive movements, for example, suturing. Perhaps some of that, we'll see not quite AI, but transitioning into automation. AI is not going to be probably for many, many years, but what we may see, I'm not sure we'll see it in our lifetime, like our professional career, but augmentation with AI, kind of where AI is not in control, but there's suggestions in real life to really enhance the performance of the surgeon and really kind of equalize the performance, not having outliers who are really great performance and outliers who are not so great performance, really kind of bring that lower people to the kind of the middle with kind of a standardized way of AI. Some of the problems with AI is pattern recognition of anatomy, which is different from human to human, right? Especially you can look at biliary anatomy. So that's why they can make suggestions, but I think for many years to come, they'll need users like us to make the final decision, what's right, what's not. But we'll see what happens in the future. But that's kind of like, anything more to me right now seems like science fiction,
Oh, well,
Yeah.
I think that, certainly when laparoscopy was started, people were kind of almost in the same boat now, where it's starting to become a lot popular. And certainly, the pendulum in terms of hernia repair was open, then laparoscopy, then back to open, and now the robot is a wonderful tool. And so, it's so curious to see not only, and I think the other thing is we only have one robot. Like, imagine what things will be when, we've really started to say, this is the different types of robotic technology that are available to us. That will certainly kind of change the game.
I think so.
Also, speaking of robotic technology, there has been maybe one group in particular that has really kind of kiboshed the robot and published a lot of data about, the robot versus laparoscopy. How do you interpret that data, and how do you say, listen, does that apply to me? Or especially with the lap versus robot inguinal, there's always the cost argument, the time argument, outcomes argument. How do you kind of navigate that in your practice?
I respect people who say we should be responsible stewards and resources in medicine. Yes, I agree, absolutely. With that in mind, I think all of us have to look in the mirror and honestly ask ourselves a question: where, if you're in the field of minimally invasive surgery, whether you're GYN surgeon, urologist, a general surgeon, colorectal surgeon, hernia surgeon, where do you see what we're doing evolving into? Especially now the robot has been around for 20 years. I think it's very clear. I mean, most people will agree, especially the robot is going to be part of our tools that we use every day. Right now, the first 20 years, it's extremely expensive, obviously, to capital cost, OR cost as well. But everything, unfortunately, in surgery is expensive, and I think whether it's going to become cheaper or not, I have no idea. I mean, if we have more robotic systems on the market, which by the way is not going to be anytime soon, even though there are several companies in the works, it's just I still find it kind of not realistic yet. But if when we have them, perhaps things will become cheaper. You know, perhaps we'll see, or they'll get at least won't get much more expensive. But you know, when we're comparing laparoscopic outcomes to laparoscopic inguinals versus robotic inguinals, I mean, I would probably, again, bias, I would not expect to find a huge difference in outcomes, right? But if you ask me, is there a place for robotics in inguinal hernia? Yes, because that's how things are going to evolve. This is going to be a tool we use on a daily basis. And you can try selectively using it or not, but as things evolve organically, this is going to become something we use every day. We're not even going to think of it as something specialized. So it's going to go, right now, we're still going through phases where robotic surgeons are specialized surgeons. This is going to be, everyone is going to be using robotic equipment. Everything is going to be like that. And it's going to evolve. It's just embrace it, accept it, and let's figure out how to be responsible about now. And if you're going to say that it shouldn't be done right now because, you know, you want to be responsible steward, okay, fine. In our hospitals, we kind of do that as well. That's reasonable right now, but understand that it's gonna change. You're not going to be doing this like that for the rest of your life. And then the studies, that some of the studies, again, not to pick on anyone, but you know, and it's not just one study, but when the studies that I've seen that compare robotics to laparoscopy, a lot of times I think the surgeons that are doing the procedures that just haven't gotten through that learning curve. And like, how do you define learning curve? We just talked about it early on. And so I think some of the outcomes are going to be very different if you do the same type of studies a few years from now when those same surgeons are more experienced. You know, so my final kind of final statement, I would say, just whoever is trying to really kind of hard to stifle this growth of robotic technology, I mean, I think they're fighting a losing war. They really are. I think being responsible and using kind of more expensive, you just have to know what you're doing and have reasons right now why you're doing using technology. But I think things are just going to change organically as we progress.
And then what advice would you give to someone that's kind of trying to introduce the robot into their hernia practice? What things do you think have made you really successful?
Sure. Yeah. I mean, take your time. Take your time to, first of all, commit to slowing down. It's a learning curve. Down the road, once you get past the learning curve, you'll see the benefits. It sometimes is going to be hard to see the true benefits early on because it's not easy to go through a learning curve, especially if you're the type of surgeon that is used to have very busy days. Doing several cases a day, and you have a standard, you're going to have to slow down, perhaps do one case less a day. Try to commit yourself initially to, first of all, if you have access, if you can get access to it at least once a week, that'd be great. I mean, not everyone can do this right now, but when you post cases, I would suggest posting a group of cases. Don't post very complex cases. Post the cases that you already know how to do laparoscopically. So again, now you are going through a learning curve, so where you don't have to worry about how to do the case because you are master in doing those cases. Now you have to kind of learn how to use the equipment. And of course, you should not learn how to use equipment on a person. There's ways now of doing this. There's simulators. There's a different programs that Intuitive has worked in. There's labs that are available. And if you start talking about more complex procedures, for those, I think you will need separate labs, really slowing down, getting a mentor. There are tools that, Intuitive. I would should take my hat off to them for really kind of being fairly responsible in the last, at least when I worked, know them for the last decade. So they've been helping mentors come together with people who want to kind of take it to the next level. So just don't rush, and being patient and having realistic expectations. Understand that it's a tool that requires time to learn how to use.
Awesome. And one question you had mentioned, is there anything that you've changed significantly in your robot practice from when you started to now?
Well, I think for me personally, my journey was I had access to a robot twice twice a month to now I have essentially 3 times a week. So I've changed to where I was selectively using doing more and more difficult cases initially to now I think I'm doing pretty much everything robotically. And can I do some of those cases laparoscopically? Perhaps, but there is also a benefit to a surgeon that we didn't talk about ergonomically now. While I can produce certain things laparoscopically, it's easier for me. My day is easier for me as I'm what I consider myself more of a master user than I was a few years ago on the robot. And ergonomically, I feel really great after the end of the day as compared to if I was to do those cases laparoscopically.
Do you think that, obviously we're very new with the robot, that the robot changes the ergonomic stresses that you're experiencing? Or do you think, like, in terms of ergonomics, the robot is like, yeah, your back might not hurt because you're not, retracting into an abdominal wall, but like, are you at all concerned about like wrist movement and stuff like that? Because certainly it is a little bit different, and it's something new that we haven't studied. And I think, do you really think it's ergonomically better, or maybe we're kind of trading one thing for another?
Yeah, that's a very good question and point. I think initially, when I was starting out, I developed different pains and aches initially. And that's why I was talking about a few hundred cases, because I definitely can tell a difference now as my body is much more relaxed. But yes, initially I would get upper trapezius kind of pain, really straining my neck because I would like push my head against this thing.
You're sleeping on the desk.
Yeah. And my hands would kind of like really spasm a little bit initially because I would just over grab sometimes. I think I would be, because I was going through a learning curve, I was a little bit more intense. And this has changed as I've done more cases, and I think I've just gotten that. So yes, there is a benefit, but I personally did not experience it until like a few hundred cases, not like 25 cases, like some people say.
No. Awesome. Well, that's all I have. It was such a pleasure to interview you, and obviously it was great to see you. I am excited to now incorporate the robot more into my practice, especially because, I think it's a really important time in hospitals these days as people are starting to get really full. And, we have now obviously dealing with a huge pandemic, and being able to provide the same hernia repair, but without the same risk and inpatient admission, is really kind of a game changer for hospital systems across the world. So kudos to you. And I think, this is the time for sure when we, really should push it to say, hey, listen, like, these people need their hernias fixed. I think a lot of times it's hard to say whether or not it's truly an elective thing, because people are experiencing pain, and any way that we can use our tools that we have to really kind of help a whole health system is super important. So again, absolute pleasure. Thank you so much. And
thank you, Charlotte. Pleasure as well. Thank you.
Look forward to seeing you soon.
See you soon. Have a good night. Bye-bye.
Take care. Bye.
Thank you.